And I need to do just one more quick introduction. Dr. Moaz Choudhary is Assistant Professor of Radiology, Vascular Interventional Radiology, and Associate Program Director for the Integrated and Independent Interventional Radiology Residency Programs. His clinical work includes advanced image-guided interventions in vascular oncology procedures. His research interests involve improving techniques in interventional radiology and optimizing care pathways for patients with liver tumors and related conditions. We are going to have a tumor board, and then we will have lunch at 1. Please stick around. We have a great afternoon, 2 great afternoon sessions, and I'm going to turn over to Dr. Singal and give these doctors a big round of applause, please.
Okay, so thanks all for sort of sitting steady for the last 2.5 hours here. So what we're going to try to do is we're trying to go through a couple cases just to highlight a couple points here, and then of course try to leave some minutes for question and answer for this last session. So I've tried to keep this relatively simple to just highlight a couple points. But the first patient that we have here is a 54-year-old male who was undergoing screening after being cured for his hepatitis C. This is important. He was found to have a mass on imaging. You can see there a single lesion that was about 3.5 centimeters. So Moaz, do you want to just briefly describe how you would think about this from a radiology perspective in terms of describing sort of the imaging there, understanding obviously you're an IR guy, but from going back to your diagnostic days, like how would you describe this lesion from your perspective?
Good. Well, thank you very much for having me. So what we see here are 2 slices for CT scan. And basically, for lack of a better word, I always tell my patients, it's like we're looking into your body from the feet towards your head. Okay. And you see where the green arrow is, that's the right side of your body. And then where the circular white dot is, that's the aorta. So at the bottom of the thing is the spine, right? So that's your right, this is the back, and then the front and left on that side. And all this gray thing that you see under the green arrow, that huge lobular thing, is the liver that we've been talking about all this entire afternoon. So normal liver on these scans, and these CTs are done, we give contrast or X-ray dye in the IV, and then we wait for a few seconds and then image them in a subsequent sequence. And the way we find this tumor is, one, if you see the entire liver has a different shade, and then right under the first image under the arrow, there is a lot of white deposition. That basically shows that it is an abnormal focus of tissue that is taking up contrast, that has a lot of blood supply. And then over decades of research, we've learned that liver tumors have a very particular way of taking up contrast. So what we see in most of the tumors is in the first sequence, we see they take up a lot of contrast. So we call them hypervascular. Vascular means blood. They take a lot of blood. And in the second phase, we see that you see how now it is actually darker than the surrounding liver. So when the tumors form, they form leaky blood vessels. So they make a lot of blood vessels and they're leaky. So these 2 image characteristics kind of make us very confident in calling this as a liver tumor. Now, over time, we've developed a grading system where we would say that this is something, and we've kind of rate them based on probability. It's called LIRADS, right? So LIRADS 1, 2, 3, 4, 5, which basically gives us a probability of how sure we are that this is tumor or not. So in somebody who has the underlying risk factors, that's an important thing. Somebody with underlying risk factors with a new mass is tumor, with arterial phase enhancement, which is the white uptake of contrast I spoke about, and washout. These characteristics make this a LIRADS 5. And in layman terms, what that means is this is more likely 100% tumor, unless proven otherwise.
Yeah, so I think that, the key thing that, so thanks, Juan. So really what we're talking about here is that this lesion that was seen on imaging has a definite appearance for liver cancer. And I had referenced before, when you're going through screening, we often don't need to do a biopsy. So Moaz talked about this system of radiology grading. And this has classic appearance on imaging where we can say with 95% certainty that this is a liver cancer. And so we treat this actually without needing to do a biopsy because of this characteristic appearance. Not all liver cancers have this appearance, but when it's present in the right clinical setting, once again, we treat accordingly. So it's a very unique aspect of liver cancer compared to other cancers. So this patient, because they were treated for their hepatitis C, fortunately continues to have good liver function. They still have cirrhosis, but their liver is functioning well. So we have grading scores for cirrhosis, and this patient has good labs. You can see the labs actually look normal from a liver perspective. The platelet count looks relatively preserved. This patient's liver, once again, is working well. So let me ask, Nicole, if you saw this patient, it was being discussed at our tumor board, this patient who has a single lesion, 3.5 centimeters, good liver function, how would you think the treatment here?
Well, as you mentioned, fortunately, this patient was found early, so they have just a single small tumor and they have good liver function. So I think the first thing we would want to do is see, is the patient a candidate for surgery to have it removed or resected while they keep their own liver?
Yeah, so that's exactly right. So the nice thing here is that this person's liver is working well. This is a patient who was found early. We have curative therapies available. And so this patient should be eligible for surgical resection, where you go in, you cut out that part of the liver with the tumor, and this patient, once again, can continue to do fine with their underlying liver intact. Let me ask, Moaz, if this patient, for some reason, wasn't a surgical candidate, let's say, they had, significant other cardiovascular disease, et cetera, how would you think through local therapies, non-surgical therapies for this patient?
Good. Yeah. So like Dr. Singal mentioned, every time we see a patient, we meet in the tumor board, and if they're not surgical candidate, that's where our role comes in as doing minimally invasive local regional therapies. So there are a few that are more commonly used. Dr. Benjamin went over them. One of them is ablation, where we put in an antenna and kind of burn the tumor under anesthesia, of course. But that has been shown to be effective to up to 3 centimeter tumors. So now this, I think, measures 4 point something?
3.5.
3.5, right? So this is at the borderline of where we think we have other therapies which offer a better result. So then we talk about the role of transarterial therapies. What that means is therapies that we deliver to the blood vessels. And as I discussed previously, these tumors have a lot of blood vessels. So we go into those teeny tiny blood vessels that supply the tumor very close to them under X-ray. And then we can inject 2 options. We can inject chemotherapy, or we can inject beads, which are reabsorbable beads that are coated with radiation, which is known as transarterial radioembolization. And the first one I mentioned was transarterial chemoembolization. Historically, before the radiation therapy came, we used to treat them with chemoembolization, and that has good results. But more and more, as our research progresses, we're getting more data that shows that when we actually inject radioembolization, or we inject radiation-coated beads, they have a longer response rate and more curative. By curative, I mean they can treat the tumor. So we have 3 options. I think given the size of this, we can either talk about transarterial radioembolization, or Y90, or transarterial chemoembolization, based on where the patient is, what facilities are available.
Yeah, so I think that this is like a common situation that we'll see in our tumor board. So once again, with the idea that we try to do surgical therapies if possible. And if somebody isn't eligible for surgical therapies, then the next thing that we often think about are what local therapies are possible. Like Dr. Choudhary was saying, that you basically have multiple different local regional therapies available. You have these therapies where you can inject beads with either chemotherapy or radiation directly into the tumor. And we heard from Dr. Benjamin that this is nice because it spares the patient from lots of other side effects. It gives local therapy. You're able to really shrink the tumor in the vast majority of cases. We have an ablation where you can try to burn it. The other therapy that we didn't talk about very much, unfortunately, our radiation oncologist wasn't able to be here today, is external beam radiation therapy. So, we talked about the internal delivery, but you can also do external radiation therapy to this, where you deliver high doses of radiation. Also, once again, are able to typically shrink these cancers well. We talked about this. So this patient underwent a robotic resection. This is also an interesting phenomenon where we can now do this in a minimally invasive manner. laparoscopically, essentially, where you can have it so the patient is able to recover quicker and go home in a very quick period of time after the surgery. So given time, I'm going to skip that. I want to talk about one other aspect here. So, Nicole, I'm going to obviously send this one your way in terms of like, what do you think here? So this is a somewhat of a similar case in the sense that we have a 62-year-old male with alcohol-associated cirrhosis, has stopped drinking, but this patient has liver dysfunction, meaning that their liver is not working well. They've had complications of their cirrhosis, including ascites, and we haven't gone through these in detail, but this is the fact that the liver is not functioning well. You have an accumulation of fluid in the abdomen because of the liver not being able to operate perfectly. So this patient was found to have a small tumor, a small cancer of 2.1 centimeters. So similar to the last patient, this patient was found early, but in contrast, the liver is not functioning well in this case. So Nicole, can you talk through like what your thoughts here are? You know, before we went to surgical resection, would you recommend surgical resection in this case?
Yeah, so you highlighted the difference in this case, which is that the patient already has symptoms of their cirrhosis. They have the fluid in their belly. And, you know, we talked about during my talk that when we try to cut out part of the liver, yes, it can regenerate, but not immediately. It can take time. So, of course, we always try to consider resection in everybody. One of the things that the surgeon will actually do is they'll calculate something called FLR, which is how much liver will be left after a surgery, and try to calculate, is that enough for the patient to survive or do well? When somebody's at this point where they've already developed symptoms of cirrhosis, they're not going to have enough liver remaining to be able to survive the surgery. And so in this case, you would need to replace the whole liver with a transplant. And so in this patient, I would recommend that they, you know, go to a transplant center, get referred there, have a transplant evaluation and kind of be checked out head to toe. And then in the interim, see, you know, Dr. Choudhary, Dr. Benjamin, to see if we can try to burn the tumor or embolize the tumor while we wait on the transplant list, knowing that from the time they meet me till when they actually get a transplant can be up to a year. So that would be my recommendation, is urgent evaluation for transplant and then to see one of these two folks.
Yeah, so the analogy that I use here is it's almost like a car teetering on an edge where it hasn't fallen off that cliff, but if you just remove more of that liver, there wouldn't be enough liver there to function. And so thereby, this patient who's actually doing okay right now, the complications are controlled, the labs look okay, but if you cut out any of the liver that's there, they wouldn't have enough left to thereby function, and this patient could thereby get sicker from their underlying liver disease, right? And this really highlights the complexity of this cancer, because we talked about this happening in the setting of liver disease and cirrhosis, and so whenever we think through the treatments, the tolerability, the outcomes, it's not just treating the cancer, it's also not upsetting or worsening the underlying liver disease. And so it really comes into all of our decision-making of what's the stage of cancer, how well is the liver working or not working, and how strong is the patient. I always tell my patients the easiest way the worst way to kill off a cancer is to kill the entire liver or to kill the patient, right? And this is one thing that we need to make sure that we don't do, that we treat the cancer effectively while preserving the patient and their liver function. And so this is one of the key things that always comes into our tumor board and highlights the importance of us getting together to discuss these things. So this patient, to Dr. Rich's point, was referred and listed for liver transplantation, underwent bridging therapy, to Dr. Choudhary's discussion, underwent bridging therapy with a local ablation, actually underwent a living donor liver transplantation. And I would argue this is the other thing that we need to think through as a group here, is that unfortunately for as many people who need a liver transplant, we don't have enough organs available. And so we need to make sure that we continue doing our part to get the word out that for those that are able to do so, that they consider donating if and when possible. And so living donation saves a lot of lives. Okay. Final case, and then I'm going to leave time for questions. I know we cut this short, but I think it's important to do so we have some time for questions before lunch. So 57-year-old female here with cirrhosis related to metabolic dysfunction, And conversely to like our last couple patients, this patient unfortunately was not undergoing screening and was found to have an 8-centimeter mass that was consistent with liver cancer and disease outside the liver. So also has a lymph node that's 2 centimeters in size. So liver's functioning well, but unfortunately large tumor and metastatic spread, disease spread outside the liver. So I'm going to start just, Nicole, Moaz, would you guys consider this patient for a surgical therapy or local therapy? And you can be brief here. So
I guess at this point, I wouldn't consider surgery right now because we know it's involving the lymph node, presuming we've proven that. And, you know, removing the whole liver, removing part of the liver won't take the cancer out of the lymph node. So I think we'd have to address that first and could consider in the future a surgery.
Yeah. So, and same idea from...
Yeah, same idea. I think like we spoke with Dr. Benjamin's talk, we do liver-directed therapy, which is therapy inside the liver. Once it's outside, then I think we need to think of where else the tumor is, and then have a discussion of the multidisciplinary with all the different specialities involved.
Yeah. So, David, what kind of, how would you think through systemic therapies here? Like, what would you recommend? You talked about immunotherapy, you talked about TKIs. And you don't have to say specific regimen, but just sort of like the classes of immunotherapy, TKIs.
Yeah. So I think to me, this patient is very appropriate for systemic therapy because, as I mentioned, you know, the advantage of systemic therapy is that it can attack the cancer where it is and where we don't see it. So it's not that, you know, the lymph node is something that's dangerous to have. But the problem is that all the lymph nodes in our body are in some way connected. It's sort of like it's like a highway, right? And it tells us, and we have, you know, a lot of historical data to tell us this, is that you could try to kill the cancer where it is right now, but it's almost certain to come back. So, you know, again, there might be caveats to this, you know, and there are possibilities, you know, patients may only have one lymph node involved, and you could, you know, treat it and may not see it back, but that's statistically, that's just going to be unexpected. So in this case, you know, the assumption is that this cancer is already spread outside the liver, it's spread to the lymph node, and it could be in other places that we don't see yet on the scans. So to me, this patient is healthy. They don't have any contraindications that I can see for immunotherapies. And so using one of our immunotherapy combinations would be a good first place to start. You know, their liver also is very functional. So this patient is ideal for that reason.
Yeah, I mean, this is a perfect patient to start with systemic therapy. So one of the immunotherapy combinations, you know, to David's earlier point, there are proven immunotherapy combinations which have changed our perspective on this. So whereas we used to have an average survival of only a year before, we now have patients, 20 to 30% of patients are having incredible responses. We've seen data where patients can survive 5 years. We see 1 in 5 patients surviving 5 years despite presenting with metastatic spread. I mean, it's a completely different era for our systemic therapy options. And so we have hope even when patients present at a more advanced stage. And so it's important for patients to not just say, oh, I have advanced disease, I should just give up. Patients should be referred for therapy. We have fantastic therapies available. And to David's other point, we have clinical trials where we're now not only just sort of staying with what we have, there's many other therapies that are coming around that are also promising, both in terms of improving tolerability and efficacy. And so this patient was treated with systemic therapy and has done well. The final case was more so a case of somebody who did not have liver disease, who was found to have a liver mass. I think the only thing that I wanted to point out there, once again, was that in the absence of liver disease, it's uncommon, it's possible, but uncommon to have cancer. There are many liver masses that are found in the absence of liver disease. Adenomas, FNHs, you don't have to remember the name, but there are many benign liver masses that are found in the absence of liver disease. So I see, like Dr. Rich and I see this commonly in our sort of practices, and it's actually, it's the best visit that I have, right? I get to go in and I get to tell this like typically young person, you don't have cancer, you have a benign condition, like you don't need further follow-up, you don't need anything done. It's a fantastic, and like invariably they're just super happy, like they hug me, like or whatever, and they walk out the door, and like, you know what I mean? Like it's the best visit. But like, once again, I think it's important for like these people to go to sort of somebody who understands the evaluation of this, because not every mass is cancer. We spent a lot of time talking about cancer, but there are other non-cancerous liver lesions that are important to differentiate. So we'll go to Q&A. I just want to highlight once again, like, you heard a ton of information, right? And it's somewhat like I don't know, if I were you, I'd be like, what do I even take away here, right? So like I would say there are several key takeaways. One, liver disease is common. Liver disease is the main risk factor for liver cancer. So like we need to do a good job of treating, of diagnosing and treating liver disease, right? So these simple steps, remember, be healthy. So exercise, and this can be, it doesn't mean you got to run a marathon. This can simply be 10,000 steps a day. Eat healthy, right? So like I know there's like a bunch of like cookies, which I also looked at every cookie there. Like don't necessarily take 4 cookies. Like there's a lot of healthy options. Try to eat healthy, okay? So no like heavy alcohol. Like it's okay to have a drink here and there, but do not drink heavily, okay? Get screened for viral hepatitis. Hepatitis B, hepatitis C. If you're not vaccinated, get vaccinated for hepatitis B. We don't have a hepatitis C vaccine, but you can get, if you get screened for it, there's a simple blood test and they're treatable, okay? If you know somebody who has cirrhosis or chronic hepatitis B, get screened for liver cancer. Finding it early is the key. The other unfortunate thing is we do see people who are found early and they get treated with some rando therapy. Not a bad therapy, but not a curative therapy. So if you're found early, get referred to a center that considers surgical therapies. You heard from Dr. Rich that the cures are local ablation, surgical resection, liver transplantation. I have to say the saddest thing that I see is somebody who went through all the initial steps right, got found early, they got started on a non-curative therapy. And the only time that somebody asked about something like liver transplant was when the cancer progressed, it was bigger, and we're like, you missed your window. The window was 2 years ago. And this happens often, and it's so sad. So if you're found early, surgical therapies are your friend. If you're not found early but it's liver localized, there's a lot of very well tolerated and efficacious or effective local regional therapies, okay? And finally, systemic therapy. If you're found more advanced, it doesn't mean all hope is lost. There are really great systemic therapies. The immunotherapies are fantastic. They can actually shrink tumors. Sometimes people are found not transplantable or resectable. These immunotherapies are able to shrink it and bring it into sort of criteria. So not all hope is lost anymore. So we have very effective therapies, clinical trials, and one thing that we didn't like sort of explicitly say, but sort of referenced in this tumor board, the most important thing that I would say is if somebody's found to have liver cancer is to go to a multidisciplinary center. Not all doctors, not all practices are the same. Go to a center that has a setup where you have all of the doctors that are talking to each other to figure out your best therapy, not only at diagnosis, but as you go through your course. Once again, the time that I typically see people who aren't treated with surgical therapies if they're found early is if they just go to whoever down the street. And if you're a hammer, everything in life is a nail. But you want to have a toolbox where you have all the therapies that are being considered and weighed.